Hello everybody. Our paper is entitled The Manual Therapy in Treatment of the Carpal Tunnel Syndrome. The authors are Nicoleta Calotă, PhD lecturer at Ovidius University of Constanta, Physical Education and Sport Faculty, Marian Achim, student of Ovidius University of Constanta, Physical Education and Sport Faculty, and also Antoanela Oltean, PhD Associate Professor, Ovidius University of Constanta, Physical Education and Sport Faculty. Carpal tunnel syndrome is the most common entrapment neuropathy of upper limb affecting motor, sensory, and vegetative fibers of the median nerve in the carpal tunnel, thus bringing often its treatment, prevention, and management into the research field. The approach of this theme was made taking into consideration the importance of the wrist joint in the professional life, sport, daily living, and the negative impact upon all these types of activities due to the functional imbalances, disorders, or injury affecting the inferior part of the upper limb, which occur frequently. The programs proposed in the specialized literature must be combined with other therapies so that the recovery of the upper limbs is of quality and duration. The treatment could be surgery for the nerve decompression when the syndrome symptom lasts more than 6 months without any relief, or conservative medications, physical therapy combined with various psychotherapeutical procedures. Different forms of manual therapy represent an efficient method to prepare the tissue for movement. As technical repertory, it enhances maneuvers executed by local pressure, passive mobilization, manipulation, various means of massage. Methods. This study had as its purpose to determine in which degree the use of manual therapy for the carpal tunnel rehabilitation and recovery improves the process. It was conducted at the Balneal and Recovery Sanatorium from Techirghiol on a period of 5 months and included 4 patients diagnosed with carpal tunnel syndrome, with no surgery intervention, having age media 51.75 years. The rehabilitation program combined various electrotherapy procedures, 5 per week, 3 weeks each subject, with physical therapy, 5 sessions per week, 3 weeks each subject, and manual therapy, 3 sessions per week, 3 weeks each subject, individualized by the subject specificity. The electrotherapy sessions were meant for the inflammation and edema decreasing. The 4 patients involved in the research were equally divided into 2 groups, control and experimental. All subjects and the electrotherapy procedure, along with the physical therapy session in which the mechanical energy were utilized in various forms: the patient voluntary motor activity, the gravity force, the force induced by the physical therapist through passive mobilization of the fingers, hand, fist, and upper limb joints. They also performed exercises for fingers, fine motor skills, and dexterity, hand integration into the upper limb kinetic chain, and bilaterality exercises, avoiding the forcing phenomenon. The experimental group subjects had supplementary manual therapy sessions before the physical therapy ones, with the purpose of connective tissue preparations. For this larger than the affected hand, fist and finger zone bodies areas were approached. The medium and superior trunk, the pectoral arch, the arm and forearm, massage and desensitization maneuver, carpal bones and median nerve manual mobilization, and stretching for the flexor retinaculum to open the carpal tunnel were performed with the objective of decreasing the local pressure and improving the blood circulation. In order to perform the functional balance of the patients, the measurement of the fist mobility were used as evaluation methods by goniometry. An initial assessment was made at the admission of subjects prior to physical therapy and one after the last session before discharge. Patients were also evaluated initially and finally by the use of Tinkle, Fallon, and Durkheim test. Initially, all presented positive results. Testing the patients, including the control group, we noticed at initial tests for the extension movement and also for the flexion movement, improvements, as well as for adduction and abduction. In the experimental group, We also notice improvements in flexion, extension, abduction, and adduction. Observing that in Table 1 the percentages of mobility recovered for each patient, we can say that the subjects of the experiment group improved their mobility in the fist joint than the experiment group. Manual therapy being a plus to recover mobility in this joint after the diagnosis with carpal tunnel syndrome. At the final evaluation of the Tinel and Durkan tests, both subjects of the control group has still a positive results and one at the Fallon test presenting paresthesia and diffuse pain in the median nerve territory. In the case of experimental group, both subjects registered negative results at the second Tinel, Fallon, and Durkan tests with no discomfort or paresthesia. One had negative, one positive result at the final Durkan test evaluation. The effects upon the inflammation and edema, decreasing of the electric procedure and the physical therapy exercises strategy are highlighted in the increased range of motion of all measured types of movement for both control and experimental groups. Processing and comparing the data obtained from the initial and final fist goniometry measurements for the subjects involved in this study, it showed that flexion, extension, abduction, and adduction progress was gained for all, but with the highest score for the experimental group subject. The manual therapy technique applied on the mechanic interface of the median nerve and the connective tissue mobilization were proved efficient upon the functional and the dynamic difficulties of the affected area, fist, hand, and fingers. The pressure upon the nerve diminished in its collision with the surrounding tissue, the local blood flux intensity were increased. Similar observation reported Gada Malitalebi and Melissa Yuntin-Tang in their researchers. The specific symptomatology for the carpal tunnel syndrome presents manifestation as paresthesia of the fingers 3, 4, 5 and the lateral face of the last one, nocturne pain, discomfort, or pain in the middle of the palm, but the fingers flexion, usually medius and index being affected the most. Thus, at the evaluation with the Tinel, Fallon, and Durkan test, initially all the subjects marked positive results. At the second evaluation, the two control group patients had still positive result at the Tinel Durkan test and one at the Fallon test. One subject registered negative Fallon test, fact that can be interpreted as low efficiency of the electric procedure and physical therapy only in median nerve decompression. The desensitization manual therapy technique and the maneuver of carpal bones and connective tissue mobilization and stretching upon the median nerve conducting the result for the experimental group in having no positive for the Tinel and Fallon test in any case and with one Durkan test positive. Thus, after the evaluation comparison of the two study groups, it can be stated that the manual therapy optimized the functional capacity of the joint by gaining a better range of motion for the experimental than the control subjects, most probably due to the tissue elasticity increasing. Same time, manual therapy diminished the subjective symptom of pain, discomfort, and paresthesia. The rehabilitation approaches stages developed as follows. The inflammation and edema decreasing the muscular force and joint mobility recovery, the hand and fingers dexterity optimization along with relief of biological stress reaction, the paresthetic sensation diminishing. All these aspects were not treated separately but by a systemic approach, taking the upper limb as a whole. Like the statistical data interpretation confirmed flexion, extension, abduction, and adduction of the fist had a significant improvement with a higher score for the experimental group than the control one. The neurological testing highlights also more progress for the subject of the experimental group. As Husted et al. And Madali, Bonging, Signorini, Bassetti shows manual therapy combined with other types of therapy can improve symptoms and function of hand for the patients who suffer of carpal tunnel syndrome. Thank you very much for the attention.